Hello, everyone, and thank you for joining us this evening for the Tumors of Spine and Extremities webinar. My name is Sandy Youssef, and I am the National Manager of Professional Education here at Ethicon. We want to keep this meeting interactive and encourage you to ask questions throughout the meeting, and we will answer your questions as they come in. In order to ask a question, please use the Q&A box on the bottom of your screen to submit your question. Josh, I'll turn it over to you.
Great, thanks, Sandy, and thanks everyone for joining us. We always enjoy these presentations, and for those of you who have been with us before, we're going to do things a little bit different today. We're going to be talking about tumors of the spine and extremities. But before we do that, want to just mention that for disclosures for all of us, we all have no disclosures to report. We are not employees of Ethicon or Johnson & Johnson, so our disclosures are the same as they have been previously. So moving on to the next slide. Again, many of you have been to courses with us in the past, and now for those of you who have been to these seminars over the past several months, we want to fact check ourselves, and we feel like maybe you guys can get to know us a little bit better. So I'm going to throw up some poll questions here, and everybody needs to respond via the poll, not via the text, but via the poll, and we're going to see how well you know us at this by now. So first question: I have a twin, but I'm 5 inches taller than that twin. Who is that person? So we'll give you about 5 seconds to vote, and then we'll put the results up. Chris, whenever you're ready, see what we got. Let's see, 57% of you said me, 29% said Sarah, 14% said Janine. Jerry, nobody thinks you have a twin brother. All right, well, I'm not going to go over the answers right now. I'm going to do it at the end. All right, second poll, second question. I once river danced with Alan Thicke. Janine, Sarah, Jerry, or Josh? This should be good. All right, let's see what the results of that are. Oh, Janine, looks like you're the winner for that one. Sarah, Jerry, and I all pretty much round out the pack three. All right, next question. I previously won American Idol. Janine, Sarah, Jerry, or Josh? Give you a couple seconds to answer that one. All right, if you want to put the answers up. Sarah. Looks like Sarah's got the lead on that one. And then Josh is taking up the rear. Okay, and then the last one, last question. I am also a Beachbody instructor. Not to be confused with, I also have a Beachbody. All right, let's see the results of that one. Wow, okay. That's pretty straight, pretty right down the middle for all of us. Okay, well, I tell you what, let's start at the top. Jerry, what are you? What was your answer?
At a time in the past, I had gone to see Riverdance. I had gone to see Riverdance, and Alan Thicke was out at a restaurant with me. Restaurant/club, and we had a river dancing contest that he didn't know he was in, but that is me. I river danced with Alan Thicke.
That sounds quite memorable, Jerry. I do wish I was there to see that. So let's see. All right, how about you, Sarah? Which one is your truth?
I have a twin. She is 13 minutes older than me, blonde hair, blue eyes, and 5 inches shorter than me.
Fantastic. Not to, that's interesting. So I have twin children. Maybe that's why people thought that I was the one with the twin, but most people are at least 5 inches shorter than me because I'm almost 6.5. I'm 6'7". So, and then Janine, how about you?
I am the Beachbody instructor. I teach fitness classes at the gym before I go to work and on clinic days, a couple days a week.
Fantastic. And for me, my truth was that I have actually previously won American Idol, although not the one, not the national. This was the American Idol at Disney World. So I ended up at my children's request competing on that 3 times and ended up winning 3 times. So that's a lot of fun. So anyway, well, now you know a little bit more about us than you ever thought you probably would. So having said that, we're going to go ahead and transition into the meat of this discussion. And Jerry, if you want to kick us off, that'd be great. We're going to talk about tumors of the spine and extremities.
Yeah, no problem. And it looks like for some reason my Zoom meeting has decided not to show my face. So maybe after hearing that I danced with Alan Thicke, I'm no longer allowed to be on camera. But
I think it's because we all know that you're actually river dancing right now, and we don't really want to see that.
I did I'm reliving that moment. You're right. Yeah, so it's fine though. I'm going to have the PowerPoint here, so we'll be able to talk our way through it. So on this topic is obviously one that's close to my heart. You know, I work in orthopedic oncology and spine surgery, and have kind of worked within those 2 fields for the last 17 years. And so certainly on a daily basis, a lot of these things we're going to talk about are things that are stuff that we deal with. And one of the hardest things that I see from PAs and other surgeons that send patients to us is trying to figure out what they're supposed to do along the way when they see patients that come in with tumors, and how they're going to manage that. So, you know, I think a lot of these things I'm going to talk through are not for if you work in orthopedic oncology, but more for if you work in orthopedics, in spine or extremity, trying to help you process and figure out how to manage some of these patients. So, you know, the first part is identifying the lesion. And I think so often when you're in a subspecialty practice, it's really important for you. You know, we may see our primary care doctors who will just order physical therapy without any imaging on a patient, but we want to make sure we get imaging and not miss something early on when we could have had an image to look at things. So it's always frustrating when a patient's like, I've been complaining of pain for 6 months and finally they got an x-ray and then it showed this lesion. So as specialists, we want to image areas and make sure we're not missing something. And if someone is failing conservative management, getting that advanced imaging, whether an MRI or a CAT scan or whatever imaging, and we'll talk through that as we go. So some of the clues when you're talking to patients, if someone is saying they had weight loss, pain at night, it's really important to make sure that you're pursuing things further. So on the image that we're looking at here, I'm going to flip to our next screen. You can see that on this view right here, you may have just thought this was the gastric bubble, but it's actually a huge lytic lesion that's occupying the pedicle on the left at the thoracolumbar junction and involving the rib. And on that same patient, he had this lytic lesion in the pubic and at the pubic area. He was complaining of right groin pain and was initially seen for hip pain and treated conservatively with therapy, and then had a little bit of back pain, so they sent him for some therapy on his back. And these images actually were similar over the course of about 6 months with progressive changes. So over time, this patient had progressive lytic changes, but they had been missed in the primary doctor's office prior to seeing this. And when they finally did find it, when they did the MRI and saw this mass, then they sent the patient over to us to have further conversations. So it's really important to study your images, have a plan on how you look at things. And if you do find something, figure out what do you do next. For those of you in the spine realm, and maybe in any realm, if you see this come into your office, this is unimaginable. So this is a patient that has a huge mass that's occupying half of the lung cavity on the right and involving multiple vertebrae. So just hearing a lot of those words in orthopedics is pretty cringeworthy for most people. But the reality of it is this lesion, whether it's this big massive lesion or it's a hip abnormality or a change in the femur, it's all the same basic conversation. Is this something that's aggressive, and is a biopsy warranted? And on this, obviously the answer is yes. How do you approach the biopsy is always an important question as well. And a lot of you that work in orthopedics, as an orthopedic surgeon, the training is don't do the biopsy, let the person who's going to do the final surgery do the biopsy. And in some places, depending on if it's an inpatient situation or a patient has a fracture, you may have to vary from that concept. But it's really important to not do a biopsy in a plane that's not the surgical plane, because then we have to resect that plane, even if that's not the approach we want to take for a resection. So the question here that is asked is there a specialist needed? And so often if somebody's not comfortable with tumors or it's more complicated, the patient may have some anxiety, or they may be very sick and not feel comfortable in a community hospital, or you may not feel comfortable with them. There's not an ICU. Perhaps your surgeon doesn't feel comfortable with the types of resections that are there, or the institution doesn't have the multiple disciplinary approach that's needed with oncology and radiation oncology, maybe plastic surgery. So there's a lot of situations where you're trying to figure out the right situation for the patient. And sometimes, and we're going to go through some cases today, sometimes they are appropriate for whatever institution you're in, or it needs to go to a place that has kind of that subspecialist. And we'll talk through some of those concepts as we go. So when you do identify the lesion, the question is, who does all the testing? So are you the one that orders a CT scan of the chest, abdomen, and pelvis, the bone scan, the MRI? And the short answer is it really varies on the situation. So often I try to have the oncologist on board very early if we know it's a lesion that's worrisome, and I have them kind of work through some of the staging, because sometimes they will order a PET scan instead of a CT of the chest, abdomen, and pelvis. And if you look here on this patient, there's obviously metastatic disease in multiple locations. You're going to have to, as an orthopedist, if you're dealing with their extremity or dealing with their multiple spine lesions as well, that you can see here, do advanced imaging yourself, meaning an MRI of the spine or MRI of whatever extremity that you're trying to look at. And in general orthopedics, it's really important. If you see a patient with a X-ray of the shoulder and you see a lesion, but it's not fully imaged, you want to image the entire bone, because if you do a procedure where you put a rod and a tumor, you want to make sure that you're not stopping that rod at a tumor that's down in the distal humerus that you didn't know was there because you never had an image down low to see that. So some of those concepts we're going to kind of talk through. So this case is one that we're going to kind of talk about here for a second, and it's an interesting case for a lot of reasons. I'll kind of work our way through. So when you look at an image, is the lesion lytic or blastic? And on this, this is a lytic lesion involving the cortex of the proximal third of the femur. And is there functional pain? Meaning if they're taking a step and they feel like their femur is about to snap, that's a very concerning finding and is likely something that needs to progress to surgery soon. So protecting that extremity, getting them on crutches or in a wheelchair or in the hospital is sometimes something that you consider. So the history is very important, and I'm going to talk you through some of those thoughts. So this is a 50-year-old female who has a 10-year distant history of breast cancer. She's a trainer for a bunch of physicians, actually, and that's how she got sent over to us, because she's uninsured. She is an instructor from a physical fitness perspective to a bunch of physicians, and she was having some thigh pain, and they did this x-ray. So she was sent over to us. Over the last few weeks, she had had increasing pain. So the question here, and we have a poll question, is what is the next step on this? So Chris, if you can put that up. So when you look at the imaging, the location and whether it's a weight-bearing structure is really important. And there's a classification system called the Morell's classification. And this bone on this image is a really good example. When a significant amount of the bone is lytic and it's in the lower extremity, that's the highest risk for pathologic fracture. You can protect an arm or a forearm a lot easier than you can in a femur or especially a hip. So a classification system gives you some guidance and some thoughts as to whether this needs to be treated surgically. I'm going to let kind of this question sort of give you a chance to look at it. And Chris, whenever you have the results. So on this patient, we're kind of talk through all of the above. This patient has a lytic lesion. They have an impending fracture. That bone is at high risk for fracturing. Giving crutches or a walker is certainly reasonable, but because of the nature of the lesion, getting in to see a radiation oncologist and getting in to see an oncologist or going into radiology to get a biopsy, these are all pretty significant process to get that to happen. And that patient's not going to be able to go in and out of offices and doctor's visits, in and out of the car. So typically in this situation, we will admit to the hospital, which was the most common answer. So on admission to the hospital, so this is a patient, again, who has no known history of metastatic cancer. She only had breast cancer 10 years ago. and with no known history. So on her workup, she was noted to have this isolated right femur lesion. So now we're at a place where is this lesion actually metastatic breast cancer, or is it something else? If she had that prior bone scan with 25 lesions, then we know that this is metastatic disease. We're comfortable putting a rod in that. But this could be a primary sarcoma, so we want to get a biopsy. So we get a biopsy, it comes back as metastatic breast cancer. So now we feel comfortable putting a nail in this and sending to radiation therapy, and oncology was brought in the hospital, and we were able to kind of go through that process. So after you radiate, or after you put a nail in somebody with an extremity tumor, or if you're dealing with a spine tumor, often you do have to consider radiation therapy. So if you have a patient in this situation, it's really important to make sure you're thinking through those next steps. And we'll talk through a case or two later with a similar dialogue. So the next case that I'm going to talk to you about is, so often we get brought in on a hospital consult for a patient with back pain. And this was a lady that was admitted to the hospital for back pain, and she was having difficulty standing, and she came into the ER and was eventually consulted on the floor, at which time an MRI was done, which showed this lesion here in the thoracic spine with spinal cord compression. So our next poll question is, we were just consulted for back pain on the floor, and this is the MRI we saw. So what do we do next? So the options here, I'll kind of talk through as we go, but radiation therapy, oral or IV steroids, again, getting a biopsy, emergent laminectomy versus oncology consult.
Jerry, while they're sorting through that real quickly, just something to think about. Oftentimes, in spine world, we get patients coming in with back pain or back and leg pain or back, leg weakness. Why is it important to really, a lot of times we're so tempted to focus on the lumbar spine. Why is it important to look beyond that? Or what are some of the keys or triggers that you look at when you're looking at, imaging at, either strictly lumbar, or do you, thoracic, cervical? What are the things you're looking at?
Yeah, well, when you get bilateral lower extremity weakness, certainly that's going to trigger you to consider something potentially in the thoracic spine. Look for hyperreflexia, clonus, those things that you in the spine world hopefully look at routinely, but you have to kind of piece all that stuff together. And when you do, you're hopefully going to look through all of the above. And obviously in this case, she had some pain in the thoracic spine with a pathologic fracture with vertebra plana here in the thoracic spine with this burst component into the canal, which is what's causing the cord compression. But hyperreflexia, bilateral issues as opposed to unilateral certainly are going to trigger you to start thinking upper or thoracic or cervical. All right, so Chris. So this one is a tricky question, and so many questions in medicine, you may do A, B, or C, and all of the above could be what ends up happening. It just depends on the circumstance. And in this circumstance, this patient was extremely hesitant to go straight to the operating room as her first treatment plan. And remember, if a patient has a fracture that is relatively unstable, doing a laminectomy alone may destabilize that patient. So if you are doing an emergent laminectomy, you want to certainly consider instrumenting that patient at the time of surgery. If you do look at this patient's images here, she does have lesions that are in multiple vertebrae that we can see in this one slice. So on this patient, we got a biopsy. We always try to start with a biopsy because how you treat the patient surgically is going to vary depending on the type of tumor. If this is renal cell carcinoma versus myeloma versus a primary sarcoma, those are all treated extremely differently. So if she's medically stable, which she was having pain and some weakness, but not weakness that showed up this morning. She'd been having weakness for a short period of time. So we did a biopsy. The starting steroids is something that's pretty commonly done. But if you start steroids on cord compression on a tumor that is sensitive to steroids, you'll actually treat the tumor. It's a form of chemotherapy. So if this is lymphoma or myeloma, you're actually treating that lesion and you'll get a negative biopsy. So now you're stuck with a non-diagnostic biopsy and you have to end up just doing a bigger surgery. So the short answer on this one is we did get a biopsy and the biopsy came back as myeloma. This is the patient 1 year after being evaluated in the hospital. So she declined surgery. We talked to her about a decompression infusion. She just refused. She was just not willing to hear that. She was started on steroids, oncology was consulted, and she was on bed rest early on because she was struggling with symptoms when she would try to mobilize. She started radiation therapy almost immediately, and you can see the radiation therapy changes here in the spine. And she was put into a brace. And so this is her a year later. Ultimately, she did not end up having surgery. And some tumors are very responsive. I think we're going to touch in a second on a couple of concepts that we just talked about in relation to different types of tumors. On this slide here, when you're talking about these different types of tumors, there's a lot of concepts that can be challenging, and some institutions may be or some may be more suited than others. I'm going to jump down to the last one because I just mentioned it on that last slide, but is this a vascular lesion? So renal cell carcinoma and thyroid cancer in the operating room, they bleed profusely. And if you go into the surgery without knowing that it's one of those lesions, you can lose 4, 5, 6 liters of blood in a heartbeat if you get into something that you're unaware of. And so it's really important to try to have a diagnosis before surgery. And if you do have one of those lesions, those can be embolized, and that's represented here, where you just cut off the blood supply to the lesion to try to minimize that blood loss intraoperatively. And even if you're doing a laminectomy or a nail, you feel like that's a pretty straightforward case. We can do that, no big deal. But you really want to try to minimize that blood loss because, first off, these patients are usually pretty anemic from chronic disease. So if somebody comes in with a hemoglobin of 8.6 and they end up having renal cell carcinoma, you're going into that surgery already a unit or two behind. And if the patient bleeds like they tend to do, you want to try to have them optimized and ready to go. When you make decisions related to the surgeries, whether it's on the spine side and you're doing a fusion and doing a corpectomy versus a laminectomy, or if it's on the extremity side doing a nail versus a resection and replacement, you have to consider, is this lesion likely to heal? Has it been radiated? Is it going to be radiated? A lot of times in the spine, we aspire for fusion, but those patients don't always heal through those areas of fusion. And you're really just trying to stabilize them and decompress the spinal cord so they can get up and start moving and mobilizing and get on with their life as much as they can. In relation to some of the patients that we're talking about after surgery, they're going to end up having chemotherapy or radiation, and that can lead to some questions related to the wound. And we're going to talk about that in just a second. And some of the patients go into surgery where they've been pre-treated with radiation and chemotherapy. So pre-surgical, that's neoadjuvant therapy, and post-surgical, that's adjuvant therapy. And that verbiage can sometimes get a little confusing if you haven't heard that much. So this slide is talking through some thought processes related to wound care in orthopedic oncology or tumor-related cases. So oftentimes when we have a patient with a pathologic or with a fracture period and we do a rod, you might do something like staples really fast because it's Friday night at 9 o'clock and you're doing a super quick closure, and you just go to follow your protocol of taking those out 7 days later or sometime relatively early. But if this is a patient that's getting radiation therapy or chemotherapy, you need to be much more sensitive to that time period of how long you leave your sutures or your devices in for closure. So oftentimes we do use Pernio in some of these because it does give us kind of that coverage for 2 to 4 weeks, and we'll kind of seal that wound off because we want that wound to kind of have the suspenders, belt and suspenders sort of support around the incision to allow for a longer healing period, because these patients by nature are immunocompromised. They're being treated with medications that make their healing delayed. So leaving a suture in for a longer period of time is very common if you do something external or a staple. If you do, I tend to not do personally a monocryl dissolving stitch on these, but I will use a #1 PDS type suture deep, and then either interrupted or staples on the skin on somebody who's going to be radiated, and we will leave them in for a little bit longer period of time. These are just a couple of cases, just of things that we look at and see and think about in orthopedic oncology. You know, if you're making an incision on this spine that's been radiated, that tissue is not going to heal in your typical way. So doing a conventional closure on this is not necessarily going to heal as well. So you really want to think through some of those issues. And obviously, this lesion here is extremely complicated, as is this, which is involving a plastics closure and a flap to cover it. So as you go through these cases, you always have to think about on the back side, if you're dealing with a tumor, who's going to be dealing with that? What are the concerns I have? Are they going to be having chemotherapy or radiation therapy? And those are some challenges that we deal with all the time in orthopedic oncology. So I'm just going to touch on a couple of pearls related to both extremities and spines from a tumor perspective. one of the biggest things I warn people on, if you read that somebody has a hematoma on a report, you need to make sure that's a hematoma and that the history goes with that, that they had trauma, that they're on blood thinners, because it's very uncommon for someone to spontaneously grow a hematoma without any of those circumstances. And I have seen many times meaning more than 5 times in 17 years, where somebody had an evacuation of a hematoma that was a sarcoma. And those lead to pretty devastating outcomes when that happens. We're going to talk through some cases and some thoughts here in a minute that will kind of put all this together. But if you ever see a hematoma on report, really be critical of it and consider getting a biopsy or having a couple people take a look at it, or make sure your surgeon is thinking as they go in, maybe make a little smaller incision and check the tissue as you go in, because you might want to get a frozen section on this lesion when you go into surgery. I put this one up because I see about 3 to 5 of these a month. They're usually sent over by our joint surgeons that refer to our practice. And this is a lesion that's pretty commonly seen in the hip. It's called a liposclerosing mixofibrous tumor. The biggest thing when you look at this from an orthopedic oncology perspective, is this bone about to break, or is this something that's stable and been there a long time? And when you look at this, if you look at the rim of this, it's very sclerotic and firm, which means it's unlikely just to cause a fracture, even though it is concerning because it's filling the inner troch space pretty significantly. When you look at it on MRI, there's no reactive changes. There's no perilesional edema evidence that this is breaking or about to break. This has likely been there for 20 years, but nobody got a hip x-ray because their hip wasn't bothering them until it is. So it's important when you look at these to be able to kind of talk through them. And if it is something you're uncomfortable with, send it on to somebody that looks at a lot of these, or have one of your MSK radiologists look at it to give you some perspective. This is not something we would biopsy. This is something we get serial imaging on, and we would leave it at that. But we do see a fair amount of those from our joints people. This is another common thing that we see from our joints and extremity people. This is a cartilage neoplasm called an enchondroma. Enchondroma and low-grade chondrosarcoma sometimes are used interchangeably, but it's just a benign cartilage tumor, and you'll see this lesion within the bone. On MRI, it will not be growing outside of the cortical bone. It's just well contained within the bone itself. If you start to see reactive and adaptive changes or a big soft tissue mass, cortical disruption, that's when you start to become anxious that it's something more aggressive like you see here, which is a chondrosarcoma. So this is obviously a much bigger issue. It's not chemosensitive, it's not radiation sensitive, and that's going to be something that needs a big, massive resection and is not probably something you're doing in just a routine joints practice. In the spine side, a couple of key things that I always like to hit on when we have an opportunity, that when you order an MRI of your cervical and lumbar spine, there's a couple things that will occasionally show up, maybe once a year, or sometimes once a month if you order enough. In the cervical spine, they'll identify that there's a thyroid mass and they recommend an FNA. I don't order FNAs, and I would not really start treating something I don't treat by getting a biopsy, but I would send that to either an ENT or back to their primary care to make sure that gets evaluated. But I see that not rarely. And then in the spine, I've seen 2 patients with kidney masses, which their primary presentation was low back pain. So when you look at that axial MRI, if you see a lesion, make sure that you look and see what the radiologist called it. Did they say it's cystic? Is it fluid filled, or is it a solid mass that needs further evaluation? And last, the most common thing we see in the spine is a hemangioma. Hemangioma on T2 here is going to be bright, and on T1 is going to be bright. And so that's a really easy way to sort of get some comfort that when you see these 2 masses in this person's spine, that is this malignant or is this benign? Hemangiomas are seen in about 10 to 15% of the population, or 10 to 15% of imaging studies that we look at on the spine side, and is one of the more common benign tumors that we see. And last, if you see a lesion in the sacrum, this is a very obvious, concerning, aggressive lesion, but if you see a lesion in the sacrum, it's really important to have that followed up with as a chordoma is a lesion that in the spine world, if you guys are seeing people with low back pain, you may see a couple of these in your career, and it's really important to take a look down there as you're looking at your sagittal cuts to make sure you're not missing anything. One last image. This was something we talked about on that first slide, but just unknowingly, the winking owl sign. So if you look at the pedicles on the vertebrae when you're looking at an AP x-ray, if there's an absent pedicle, that's called a winking owl sign. That means that the cortical bone has been eaten away by a lytic lesion. And when you're looking at your AP x-rays, you just want to look for symmetry pedicle to pedicle really quick on your AP view. And that's a really quick way to look for lesions that are occupying space within the bone. And then painful scoliosis in a kid. That's the one thing. If someone truly has pain and scoliosis, is there something more to the story? And an osteoid is a very common lesion that is seen in the body in extremities and spine. But if it's in the spine, it can cause someone to have scoliosis. And I'm going to transition now over to Janine to talk through our first case.
Well, thanks, Jerry. I feel like I always learn so much from you just listening to this as well. And the enchondroma is the one take home for me. That's a good pearl. It always looks a little scary. I know Sarah's nodding because she sees a fair amount of those. And, you know, patients always have questions too, you know, what's that? And sometimes it's just gas. And, but they always see the enchondromas as well. So it's nice to have some confidence and actually know what it is and be able to explain a little bit to them. But in my case, it's a relatively quick case, but very interesting. And I like this patient very much. She is, at the time of this case presentation, she was 58. She had bilateral hip pain. She came to see us, and you can see she's got bilateral hip arthritis. The left was a little worse than the right. She had kind of all the classic hip arthritis symptoms, pain in the morning, stiffness at rest. You know, her exam was pretty typical. The groin pain, couldn't put on her socks and shoes. You know, she really lost, you know, the quality of life, daily activities, all those things were affected. And she had teenage children at that time that she couldn't do the things she wanted to do with. And so her pain was just getting more and more persistent despite all the conservative treatment. So if we go to the next slide, I think there's a poll question on there, but we did schedule her for a bilateral hip replacement, and we did her left side first because that was the most symptomatic. And, you know, we're very early on, 3 minutes into the case. We go to make her fascial incision, and all of a sudden, just something poofs right out at us, like very, very vividly. This puff of tissue comes right through the fascial incision. So clearly something abnormal has just happened. And I guess my poll question for you is to vote on essentially what do you do? So, you know, I was pretty taken aback. I've been doing total joints at this point I've been doing it 12 years now. This was not that long ago, but, you know, almost a decade. And luckily, as being the physician assistant, I don't have to make the ultimate decision. But, you know, in that point, you know, what do you do? Or, you know, I think all of us were in the room, kind of part of the discussion as the team. You know, what do we do, if you will? We try to take this tumor out and remove it, you know, wait 20 minutes for a frozen section, or 20 plus minutes. You know, that's, you know, the minimal time it's going to take to get a frozen section is going to be at least 20 minutes. So, you know, you have the patient under anesthesia. You've blocked a lot of time to do both of her hips. So, you know, time's not an issue, but she is under anesthesia. That's a long wait. Do you just close it now and cancel the surgery because no one is quite sure what's going on? Or do you just continue and do the hips, the one hip, the both, you know, depending. So let's see what everybody wants to do. Okay, that seems pretty reasonable. Nobody is gung-ho on proceeding. That wouldn't have been my vote either, but many of you are up for waiting to see, you know, if the pathologist has any information, and many of you are very cautious too. Close and cancel, 33%. Most of you want to wait. So pretty good. The pathologist came in and had some fancy slides and imaging, and basically we go to the next slide. We'll say that he wasn't sure exactly what was going on, but it was suggested when he looked at the slides that this was not something positive that we wanted to mess with. So essentially we did what the other percentage of you were saying, which was, you know, pretty much get out of there, close up, and cancel the rest of the surgery. So I'm going to flip around a little bit here, but that's what we did. We closed and sent the patient on to orthopedic oncology. And I'm going to bump back to Jerry a little bit here. I've learned a lot, again, from him and in this specific realm. But, you know, Jerry, as far as closing this patient at that moment, or, you know, in the future, anybody else who might be in a situation like this, what consideration should I have taken or someone else in the future take when closing something, you know, that could be dangerous, or a wound such as, you know, this case here?
Well, first off, just y'all are to be commended because you really followed the pathway here in a perfect way, and this can be very challenging because these moments happen, and we see them a lot, and sometimes people make a different decision than what you did. But yeah, you get the frozen section, and that 20 minutes feels like an hour, and you wait to confirm the diagnosis before you close, because they might need more tissue, and they may ask for more tissue. So being there while they're open, you have the ability to get that biopsy that you've already kind of worked through. As you go to close these wounds, the most important thing to remember is the bigger needle that you use and the larger bites you take. Sometimes if you're doing something where you're kind of slamming on the brakes and you're kind of provisionally closing, somebody will do like a vertical mattress with a large needle, and you take a bite of a lot of tissue on both sides of the incision. Well, if you're dealing with a tumor-related issue and you don't know what that tumor is, if you take a larger bite as the tumor surgeon, from our side, we take a 3 to 5 centimeter margin around what you did already. So in that case, if you take a large bite around your incision, we're going to take a big margin around that. And on the next slide, Chris, do you mind advancing, please? On the next slide, you can see here in the upper right image, you can see the ellipse around an initial biopsy, and you can see the amount of skin that was taken for an incision that was maybe an inch in length. So it's important to try to take minimal bites when you do, and whether you're closing with a monocryl or a nylon or whatever you're using, to try to make as small bite as possible. And this is a situation where doing something on the skin like a dermabond or something, so you have something that's not penetrating, that's not going to potentially have tumor growing out of it afterwards, it's really important. So this patient got sent to us. This is Janine's patient, not technically sent to us, but if we saw this patient, kind of the way this goes is we want to confirm the pathology. So we have a pathologist that we trust in our institution, and we have them take a look at it to confirm what the diagnosis is. While we trust people in the community, we always want to make sure before we start doing a procedure that we agree with the diagnosis. And then we talk about it as a group. So we have a musculoskeletal radiologist, a pathologist, a radiation oncologist, an oncologist, and multiple surgical oncologists. So it's a kind of 5 different folks that get together every other week, and we go through 5 to 10 cases like this, and we come up with, make sure we have the best plan for the group. On this patient, obviously getting advanced imaging and MRI and understanding what structures are involved, and then we move forward with resection. And whether there's neoadjuvant or adjuvant radiation or chemo, it really depends on the type of tumor. So it's really a big group that makes these decisions, and that's why it's really important to pause on something that you're not sure about and not to just disrupt that kind of well-contained tumor and potentially add some challenges. So, you know, Janine, what you all did is exactly what we would aspire for. Next slide, Chris. So after the resection now, the oncology does their workup, and eventually down the road, those patients get cleared. And Janine, I'm going to hand it back to you.
Thank you. And I know Pamela was asking too over the chat if we could see the plain film again. And so here it is in the same slide. And even on re-examination too, there was nothing that seemed to be indicative of that. It was definitely a soft tissue mass. There was nothing that was metastatic disease, even with the workup. So I think this is where, Pamela, you're probably trying to circle back and really look and examine. Hopefully this is answering what you were looking for. But patient was cleared, as Jerry said, by the Jerrys of the world. And of course, you're welcome, Pamela, the joint pain continues. This did not clear her osteoarthritis up. So we were able to proceed with her bilateral total hip arthroplasty, and she did very well. So you think she's cured. Unfortunately, I've gotten to know this patient very well over time. She's still very nice and sweet, but on the next slide, she continued to have more arthritis in her body, and she came to us with some knee arthritis. Not unusual for patients to continue to have arthritis, so I treated her for conservative knee arthritis, and she'd had persistent knee pain for several years. And actually, I don't have the exact picture I'd like to show you here, but there was a small condyle fracture she had, and actually I found that on her preoperative film. So this was on a native knee film, not the exact one you're seeing here, a native knee film that had a small condyle fracture. And of course, the concern for us was is this a lytic lesion that has fractured? Is there some type of metastatic disease? So we actually did send her back to the oncologist just to make sure that we were not missing something before we proceeded with what you see now, which is her right shoulder knee replacement. Fortunately, everything was fine, but Jerry, I don't know if you have anything to wrap up this case for her, but that was something we were just very concerned about, knowing her history.
No, I think you did again the right thing. You just want to make sure that you're not just treating something in the way that you normally would do. Make sure that they're cleared by oncology, where they do a PET scan or a bone scan or advanced imaging like an MRI. You just want to make sure that there's not a lesion that's potentially a source for something to be appearing once you know that that patient has a history of that. Especially if they have a known history of metastatic disease, you want to be very critical.
Thanks. That's all for her.
Great. Thanks, Janine. So, for the sake of time, I'm going to go through this case pretty quickly. I know we got a little bit of a late start due to some technical issues, so I want to make sure we get through all these cases. So I just want to go through this pretty quickly just because there's a couple good pearls that we can pick up from this. This case, this is a 62-year-old male who initially presented with back pain. And he underwent a kyphoplasty, and at that time, excuse me, he was diagnosed, found to have myeloma. So this picture, or the patient now presents, I think probably about a month or so after surgery, after his kyphoplasty, and seen in clinic for persistent back pain. So he finished his course of radiation, or is finishing radiation, had his kyphoplasties, and for follow-up, he's got back pain. He does complain of some balance difficulties and primarily mechanical mid back pain when standing. So these are the images that we got. And, in further history, he declined surgery on a previous visit, so was given TLSO to provide external support, which we oftentimes, as you know, will use to essentially functions like an external cast. So really to stabilizing the spine, so you get some adequate pain relief, but not always very successful in treating these fractures. The patient was presenting monthly for follow-up visits, and then continued to complain of progressive balance issues, and then developed hyperreflexia in his lower extremities with a persistent and increasing back pain. So poll question here is for you guys is, if you'll put that poll question up, which of the following findings on the studies is most concerning to you? Now, obviously, the increasing back pain is not something you see on the study, but that's definitely something that we would take into consideration on the history. Edema on the residual body of the MRI, signal change in the spinal cord, or the progressive kyphosis on X-ray, and then the air in the disc space on the CT. And if you can, for those of you who need to move the box, you can actually move that poll box around. So here is the CT scan. So if you could take a look at the CT for a moment, and then we'll go back and look at those other imaging studies. And I want you to think about which is more concerning, the findings on this CT scan compared with the, and let's go ahead and go back to the other scans versus the findings on the MRI or X-ray. So go ahead and submit your answers. And okay, let's see what the results are here. Excellent. Signal change in the spinal cord, and that is definitely the thing that you are most concerned about. Although I will say progressive kyphosis on X-ray and the disc space is also a very concerning finding, particularly in the face of increasing back pain and lower extremity weakness. And the reason is because you do worry about, and you can already see there's some compression on the cord, and as that kyphosis worsens, then you also can develop some draping of the cord over the bone or over the fracture. You have canal compromise. You worry about progressive and permanent neurological damage. But again, the most concerning thing on this at this point is the a signal change in the cord. So as we move on to the next slide, let's go one more. So this patient ultimately progressed to laminectomy of the thoracic cord compression, again, primarily to relieve the cord compression, ended up with a posterior fusion stabilization to correct the kyphosis, and then prolonged healing and fusion secondary to radiation therapy. And I think Jerry alluded to this earlier. The thing we worry about in these patients, not just spine patients, but cranial patients or any other patients that undergo surgery or radiation, is we worry about not only the healing and and the fusion side of the bone, but also the wound healing. So just something you want to keep in mind when you're closing these wounds. You need to be very thoughtful and methodical about how you're closing these wounds, particularly if they have had or are going to undergo radiation. I think that the two takeaways for this would be, one, even though this patient, ended up with a multi-segmented fusion, you need to continue to follow these patients closely, because you do worry about adjacent level kyphosis or breakdown at the level above or below the fusion site. So that's something that you'll want to follow continuously. And the other thing that I think is important about this case is we very frequently will see these patients who have, back pain and just, traditionally run-of-the-mill compression fractures. And I think it's important that we don't, particularly in the elderly population, we pay close attention to what those what the pathology results are when we get those. A lot of times we'll do those path in the OR, but don't just automatically chalk these up to osteoporotic compression fractures or acute fractures. Of course, for acute fractures, we don't generally treat with kyphoplasty, but just keep in mind that that you need to be thinking about what are the other things we need to be worried about when you start to see these, what some of us would probably consider run-of-the-mill compression fractures. Let's see, next slide. And I know that was fast, but I want to make sure we get a chance to get to Sarah's case. So Sarah, take it away. I think you're on mute, Sarah.
Thank you. Sorry about that. So our final case of the evening is a 60-year-old female. She has a known history of metastatic breast carcinoma. She began to have left femur pain a few weeks ago. She was walking in her kitchen and felt a snap. Kind of her pertinent past medical history, she's on hormonal therapy already for her breast cancer. She had a recent bone scan which showed bony lesions to the rib and multiple lesions to the spine. And that brings us to our first poll question. So you've got this consult. What is your next step? Do you transfer the patient to an orthopedic oncology institution? The question is, does this patient need a specialist? Does this patient require a multidisciplinary approach? Is the next step to resect the distal femur, do a distal femoral replacement and total knee arthroplasty? Do we need to get a biopsy to establish a diagnosis? Is an intramedullary nail, an IM nail, is that an adequate construct for this fracture? Or do you treat this non-operatively with a cast and radiation therapy? So we'll bring those answers up. And the majority says IM nail fixation. And so we'll kind of go through the rest of those answers. This is really a fracture that needs to be taken care of. Any orthopedic surgeon can put an IM nail in a femur, or should be able to. So it doesn't necessarily need an orthopedic oncologist to fix this fracture. No one decided to go for the big whack right away, and that's appropriate. Some of you said a biopsy, and the question is, do we need to establish a biopsy? We know she has a known primary, and so we don't need to necessarily establish a diagnosis because we already have it. Now, with that being said, when we do that IM nail fixation, sending the reamings to pathology for confirmation could be something to consider. And then thankfully, no one decided to put this patient in a cast and radiate the bone. So we'll move on to the next slide. And we did put an IM nail in. She did receive radiation after surgery, and she was made weight bearing as tolerated. And next slide. 6 months later, she starts to have increasing pain. And she's kind of gone backwards. She was weight bearing as tolerated, and now she requires a walker for ambulation. And you get x-rays and you see, unfortunately, non-union with fracture of the hardware. So now what do we do for this patient? So we'll go to the next slide. Why did she develop this failure? Well, we know that chemo and radiation can suppress bone healing. And so we really need to keep that in mind when we're thinking about an ORIF. So any post-radiation bone that fails the first ORAF is going to fail any other internal fixation. And so unfortunately, the next step for her is resection of that distal femur, putting in a distal femoral replacement, and total knee arthroplasty. Putting a plate along that IM nail or trying cerclage wires, unfortunately, just isn't enough at that point. And so you need to think of ways to augment this construct. And in the spine world, you often think of BMP, but it is contraindicated with active malignancy. So unfortunately, we can't augment with that. And so we're left with augmenting with bone cement. And that's what we did for this patient. You know, the other thing to think about, and Jerry had mentioned this at the beginning of the case, is making sure that you image the entire bone that you're putting hardware in, making sure that there aren't any lesions in the proximal femur or down in the tibia, which could compromise this construct as well. So this wraps up our final case. I'll hand it off to Sandy.
Thank you so much, everyone. I want to thank our wonderful faculty for sharing their knowledge with us tonight. I think this was incredibly beneficial for all of us. And thank you to as well to everybody who joined us for this webinar tonight. We really do appreciate it. And don't forget, your learning journey does not need to end here. Tomorrow, you will receive an email that will provide you the opportunity to participate in an optional virtual one-on-one hands-on experience with our faculty called the Ethicon Expert Exchange, and receive a wound closure kit, which contains instrumentation and samples of the products you heard about today to utilize during that one-on-one session. This email will provide you with instructions on how to schedule these sessions. For additional learning opportunities, you can also visit us at the Johnson & Johnson Institute.com page. And you'll also notice here, Chris, if you don't mind picking up the actual page, you can find our pre-recorded webinar series by clicking the on-demand webinar button. And you'll see one of our previously recorded sessions is already up and available for you guys to view at your leisure, called Adding Value to the as a PA or NP. All right, everyone, just wanted to thank you again for joining us tonight. If you need anything else, please don't hesitate to reach out to your sales reps or to me. Have a wonderful night.